We're taking this, 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 we're taking with a pinch of salt.
Welcome back, ladies and gentlemen. And for those of you that are with us for the first time, welcome to A Pinch of Salt, a podcast by ERA. My name is Emilie Cornec-Le Gall, and with us today is Professor Emilie Cornec-Le Gall. Emilie is a professor of nephrology at the Department of Nephrology of the University of Brest in France. She's an expert in genetics and nephrology and the current vice chair of the ERA Genes and Kidney Working Group. Today, we're going to be talking about genetics from the perspective of someone who knows very little about this, like myself, for example. So you can expect to hear about when we should do genetic testing, how do we interpret the test results, do we need a geneticist for the interpretation, do we not need one, what kind of genetic testing is out there, and much, much more in a nice little short bite size. So, Emilie, welcome to A Pinch of Salt, and thank you for joining us today.
Thank you very much, Professor Cornec-Le. It's really a pleasure to be here with you.
Now, genetics is a very daunting field for most of us, I believe, because we haven't been used to it that much, not like pathology, for example. But it is a very important one. At the end of the day, one could say that most chronic diseases do materialize or happen because of a bad combination of genetics and lifestyle. And decades ago, we didn't have a lot of tests to do, genetic tests, so that wasn't maybe that important. But now this is changing very rapidly. So we should all get into this a bit more, I believe. And I guess the first very simple question would be, when should one be vigilant about a possibility of a genetic disease? When should one think about testing, doing genetic testing, and what kind of testing should one do?
Yes, so this is actually a very large question. And of course, there are some red flags that should make us think genetics. Like, for example, a positive family history, or age at onset, or disease course, or specific extrarenal features, which are all arguments which can point towards a genetic kidney disease. However, none of them are required to diagnose a genetic kidney disease, and importantly, a negative family history does not rule out genetic chronic kidney disease. So besides the need to obtain a precision genetic diagnosis, there are also a specific setting to consider, such as if a patient would make reproductive decisions, or if a patient is being prepared for a transplant, which can also be a good reason to reconsider the possibility of a genetic kidney disease. I would like to emphasize that taking a family history takes a lot of time, but it's actually very precious and very informative. And I think that when we are using more and more electronic health records now, we have lost a bit the pedigrees from the medical chart, but it's very precious. And sometimes we are missing key information, even if, of course, even in the case of negative family history, we can have a genetic kidney disease. Now, regarding which test should I order, it does obviously depend on the countries and the accessibility to either panel, exome, or genome sequencing. There is a very limited role now in 2024 for single gene testing, because it's actually longer and more expensive than having the whole exome sequence. And so the usual genetic tests that are used are either large panels that can be custom panel or virtual panel applied on exome sequencing data. Or you can order exome sequencing. So exome is the coding part of the genome. It's 1% of the genome. Or you can go for genome sequencing, but in this case, it's important to have several family members involved in the analysis for the purpose of filtering the variants afterwards. And also, in some specific case, we can order a specific analysis to look for large deletion or insertion of this depends on the specific setting. So I would say that when in doubt of what is the correct genetic analysis to ask for, it's always important to get advice from expert centers, and depending on the disease and your country, there are some national reference centers or European reference centers like ERCnet, or specific groups like the Genes and Kidney ERA working group, where people can give orientation on specific cases.
Yeah. So the way I understand this, mostly what's done nowadays is whole exome sequencing in the majority of cases, if I'm correct. I don't know. You can correct me about that. And of course, the whole exome sequencing, all the exons, that's about 20,000 genes, if I'm not mistaken. So the geneticist only looks at particular ones. Is that correct? Thinking that these might be involved with this particular clinical picture. And this list that is being checked in exome sequencing, for example, can change through time, right? The knowledge changes. So I guess the geneticist really needs to be up to date about which genes, which exomes to check. Is that right?
Yes, so that's correct. I would not say that exome sequencing is the only solutions, because depending on countries, there are some, and depending on diseases also. Disease group, I would say, some large gene panels with, for example, in ADPKD, PKD1 gene is a bit difficult to analyze, and some parts are not correctly captured by exome, although it's pretty well covered. So some labs of molecular genetics may customize a bit the capture of PKD1 and prefer to have a kidney panel rather than an exome as a first approach. But so exome is a very well, it's often what is proposed, as you say. And on this exome, there would be some, as you mentioned, virtual panel that would be applied that need to be updated periodically. And it's always important, but we'll come to that in case of negative result, or I would say unconclusive results, to wonder if analysis was up to date and when it should be reanalyzed.
Yeah, so what I get from this is that you really, it's impossible, I guess, to do genetic testing well without the input of a geneticist who's very heavily involved with this, because how could I, as a clinician, know if the panels were up to date? How can I hope to answer whether a variant is important or not? I don't. It doesn't seem to me like we can do this on our own.
Oh, you're right, and it's really, I would say, a duet. It's exactly the same than what we do with pathology in nephrology, right? The kidney pathologists have their expertise, and as nephrologists, we gained. Some of us are very familiar with kidney pathology, and others less, or there are some areas of kidney pathology in which we are more specialized than others. And having this case conference where we confront the genetic findings with the clinical findings is very important, especially when you are looking at a very broad kidney disease category. When you have a strong orientation or clinical diagnosis orientation, it's easier. I mean, if you have a typical presentation of Alport disease and you find a pathogenic variant in COL4A5, and of course there is, but in some cases it's less easy, and it really requires the confrontation of both this expertise.
Yeah, so if you want to do more of this, you really need to establish a good working relationship with your local geneticist, right?
Exactly, this is extremely important. As nephrologist, you need obviously the expertise in terms of variant interpretation, but the molecular geneticist needs your participation, for example, obtaining familial co-segregation analysis, because this is very important to reclassify some variants. Sometimes we think that a variant may be causing the disease, but we are not sure. This is the case of the variant of unknown significance. And in this case, what can be helpful is to segregate the variant in the disease with the disease in the family. And if this variant is identified in several affected members and is absent in the unaffected members, it could be a good argument to reclassify it as pathogenic if this segregation is wide enough. And this is sometimes a frustration of our colleagues, molecular geneticists, when they don't get this input from the nephrologist. So it works both ways, and it's very important.
Yeah, I really like that you made the analogy with pathology, because it sounds incredibly similar in the sense that sometimes things are simple, as in histology, sometimes it's very clear cut. And then there are times when you're not sure, and then they do need the clinical input, and you can obviously only get to the real answer together. So especially with a negative result, I think you always kind of have to trust that they've checked the genes that are important and that there's nothing there. So you have to have the trust in that they're doing the right thing. And then again, there might be a gene that's not known yet. So a negative result doesn't automatically mean it's not a genetic disease, right? So it's something that we might not know yet, right?
Yes, and we never know, in fact. And it is also a key information that you should give to patients before ordering a genetic test, whichever test it is, if you ask exome, genome, or that the absence of identification of a pathogenic variant do not exclude the possibility of a genetic disease. Diagnosis yield varies according to disease categories. It can be over 60% in cystic kidney diseases, for example, even over 90% in case of classical forms of ADPKDs. It will be around 50-60% for autosomal dominant tubulointerstitial kidney disease, and it will be 17% in kidney failure of a known cause. It will be 10-15% in acute. So there are many reasons for which a test could be negative. Sometimes variants are not present in all the cells. It's a case of mosaicism. They are hard to catch. Sometimes the variant is in a region of the genome which is difficult to analyze. For example, MEK1 associated kidney disease, MEK1 nephropathy. Or sometimes the variant can be in deep intronic regions, and for example, in an exome, it will be missed because the exome sequenced the coding portion of the genome and not the deep intronic regions. And sometimes large deletions are not correctly searched for. So it's important to know if the analysis also included what we call the CNV, so the copy number variant analysis, if deletions were looked at. And also, obviously, new genes are still being reported. So it's important to know which panel was performed, which genes were included, and this is this should be written on the genetic results. There is a list of genes, and so you should have this information. Yeah. And it's important also, I think, to write on the clinical report that this specific type of genetic testing was performed in which year, and it's very important because then when you will see the patient again, maybe 3 to 5 years later, you will say, oh, okay, maybe I will update now, or I will ask a reanalysis of the exome or genome data. This is
oh yeah, I didn't think about that. Of course, you could do that for somebody who has already been tested. Yeah. When we do get test results from genetics, we often get information on variants that we know that are pathogenic, where we can safely say they are. And then relatively often we get something that's called a variant of unknown significance. Could you perhaps try to explain to us what this last one is, the variant of unknown significance?
Excellent question. So variant of unknown significance are rare variants that cannot be classified as pathogenic, and the key message is that they should not be returned as such to the patients. If the molecular geneticist decided to return this VUS, it is to allow further investigations such as family co-segregation, and it's also important sometimes to ask to expertise center what they think about this VUS, but not use them in the clinical setting. And I would like to add that this year there was a very good webcast by the Genes and Kidney Working Group, which is how to interpret genetic test results, that is available on the ERA webcast page that I would definitely advise to watch.
Yeah, that was an e-seminar, I believe, on the 8th of October. You can find e-seminars also on YouTube page if you don't find it on the ERA webpage. And like you said, 5 years after the test, you might revisit that same test and get more information, right?
Exactly, because this variant may have been reclassified either as neutral or pathogenic. We do not have enough functional assays to assess the variants in 2024, but it will be the case, obviously, later on. And larger database also are very precious to help with the interpretation of these VUSs.
Okay, it's kind of comforting to understand that it's not just complicated to me, it's just a complicated field in a way. So it's obvious that you can do genetic testing to get the diagnosis. However, of course, people want to know and doctors want to know what's the prognosis of this condition? How will it evolve over time? And also, what's the recurrence risk after transplantation? And sometimes that's a bit more trickier than getting the diagnosis. So I'm wondering, because you have a lot of experience, how often do you think that the genetic testing can actually help in assessing the prognosis and recurrence risk after transplantation?
Thank you. Great question. So for the prognosis, there are some diseases in which indeed genetic can bring prognosis information. One example could be ADPKD. And depending on the type of variant and the gene, you have different outcome. And when you combine genetic data with clinical data, we had developed a prognostic score a few years ago, which is called the PKD score, for example, and we can really stratify the risk to progress to kidney failure. So this is an example. It's not the only example where genetic can have a prognosis value. In terms of recurrent post-transplantation, this is extremely important There is nothing more frustrating than making a diagnosis of the initial nephropathy when it recurs on the transplant. And this is a minority of inherited kidney diseases, but it will lead to the graft loss in a majority of the cases. And examples would be, for example, primary hyperoxaluria. There is another disease that is less well known, which is APRT deficiency, which can also recur on the transplant, and obviously atypical HUS. So for these three examples, there are actually specific therapeutic strategies to prevent recurrence of the transplant. So it is particularly important to have a precision diagnosis. And on the other hand, reassuring patients on the absence of risk of recurrence on their transplant is also an important information. It's quite reassuring when we have a precision diagnosis.
True, that's true.
And so another important field in a setting of future transplantation is the evaluation of potential living-related kidney donors to make sure that a candidate donor is not actually carrying the same variant that caused the disease in the candidate for transplantation.
Great. I think things are much clearer now that you have enlightened us a bit, and particularly this importance with working with your geneticist, which is not always the case in centers who haven't really been focused on this. It's usually something that you have to start by your own or with somebody from the other part of the field. So now we're off to more getting to know you kind of questions. But before we go to that part, I would like to ask you, what would be one message, one advice that you would give to our younger colleagues, or perhaps even to yourself when you were younger? That's also sometimes an interesting mental exercise. So what's one message, if you could give one message to a younger colleague or yourself when you were younger, what would that be in terms of medicine, of course?
To a younger colleague, I would advise them to join the Genes and Kidney ERA working group. So I
Very
think,
good.
more seriously, nephrology needs more nephrologists with expertise in genetics. And this is a great choice of subspecialty if you're looking for one subspecialty on the top of nephrology. This is an extremely interesting field. It's like anatomopathology case conference, but with genetics, and you get to learn new things every day, even after several years in the field, because there are so many different rare disorders. So you can crack cold cases, and you can put an end to diagnosis odyssey with very important consequences in terms of familial screening, in terms of genetic counseling, in terms of specific therapies and personalization of follow-up. Gene and variant-specific therapies are under development in different inherited kidney disease, and we need more precision diagnosis if we want to move to this next step. So my advice would be get interested in nephrogenetics.
Yeah, that's very it's a very convincing piece of advice. It's definitely an up and coming field for sure. So the last questions, which are the getting to know you ones. So the question is, it's a pretty standard question, but it's still interesting. Which book, two songs, and luxury item would you take to a desert island?
So book, I think I would take In Search of Lost Time by Marcel Proust, because I never took the time to read it, and so I would have plenty of time. But I would also bring the book that I'm reading now, which is All the Light We Cannot See by Anthony Doerr. And I don't know if you have read it, and Andre, but there is a radio podcast in this novel of great importance. So that made me think about the work you're doing here. So you can read the novel.
All the light we cannot see. Is that right?
Yes.
Okay. Nice. Thank you.
And so the songs, it would not be a song, but a piano concerto would be Rachmaninoff Concerto for Piano 2 and 3.
Oh,
They are definitely my favorites.
oh yes.
And the song would be La Quête de Jacques Brel, so The Quest, and The Quest from Jacques Brel, which is a Belgium-French singer.
Very
Belgian French
wonderful choices. Wonderful. I'm also a huge fan of Rachmaninoff.
singer.
Huge fan. I just saw this year both of them, the second and the third concert. It's an amazing experience, especially if you can see it in person.
Oh, lucky you! Yes.
Yeah, I was really lucky. Yeah. I think the second part of the second concert is, I guess, the most beautiful musical representation of somebody who has just come out of depression.
Yes.
That to me is the sound of somebody coming out of depression, which is what happened with him at the time. So,
yes, he was distraught at the time. I read that too.
beautiful.
Mhm.
Emilie,
And luxury item, I would, I don't know if a wing foil would qualify as a luxury item.
which item?
A wing foil. So
Wing
it's
foil.
yes, because so it's a board with an hydrofoil, and then
Yeah. Okay.
so because
Yeah.
if I'm stuck on a desert island, I would have time to master it, and then I could use it to escape when I'm tired of being alone.
Absolutely. Wing foil in the morning and Camille for the evening, I guess. Okay, Emilie, thank you very much. I think this will be very good for our audience. Like I said, most of us are not very into genetics, and some of us should be more for sure. And I think this is a great start to try to untangle the world of genes and how you could make them useful. So thank you very much, and we'll hope to hear you soon again.
Thank you very much, Andre.